Good evening, respected doctors. On behalf of Brinton Pharmaceuticals, I welcome you all esteemed delegates in today's webinar, which happens to be the second masterclass in this series, as we had our first webinar in the last month of January 2022. December 2021. The subject was non-cultured epidermal cell suspension method. It was attended by participants from India and abroad as well. We thank you for all your encouraging response. If you wish to watch the first master class and if you have missed it, you can always go to Brinton Pharmaceutical Limited's YouTube channel and watch it again. Moving forward, vitiligo management has always been a challenging subject, as vitiligo not just fades away the color from one's skin, but also from his or her life, isn't it? Brinton Pharma, with an intent to uphold the scientific dissemination, knowledge dissemination, are indeed humbled to welcome all respected doctors and postgraduate dermatology students to the second master class today on the subject of punch skin grafts. We have a stalwart with us today who would be guiding us on the another surgical method for better management of vitiligo. I'm delighted to welcome renowned vitiligo specialist Dr. G Ravichandran sir, senior consultant in dermatology, Apollo Hospitals, Chennai, India. It's an punch skin grafts is a surgical technique that is used in the treatment of vitiligo. Apart from this, Dr. Ravichandran would be taking a few more master classes in the upcoming months on four more subjects like ultra thin epidermal skin grafts, blister grafts and hair follicle melanocyte grafts, medical therapy, recent advances in vitiligo. Dr. Ravichandran sir is one of the leading and well-known vitiligo and pigmentary disorder specialists of India. His work, spanning more than 35 years in the field of dermatology, has been appreciated all across India and abroad. So before I hand over the session to Dr. Ravichandran sir, I would formally introduce him to you with his achievements. He has graduated from Madras Medical College in 1980, then did his diploma in dermatology in 84 and completed his MD in 89. He has been a postgraduate teaching faculty in the Derma department of Stanley Medical College in Chennai for more than 15 years. After that, he has took VRS from the professor and he has got trained from Professor P.N. Bell's Institute of Dermatology, New Delhi. He has conducted many dermatosurgical workshops for dermatologists and many CMEs. He has been examiner for fellowship in dermatosurgery in Bangalore Medical College and Rajiv Gandhi Medical University, conducted many national and international presentations and publications. He has been co-author to dermatology chapter for Apollo Hospitals textbook of medicine. He has been conferred with Professor Dr. Patrick Esudian First Oration Award at QTCon TN Tamil Nadu 2015 on past, present and future on vitiligo. Dr. Ravi was awarded as Best Dermatologist Chennai, which was presented by then Tamil Nadu Health Secretary in 2017. He has special interest in vitiligo surgery and cutaneous oncology. Dr. Ravichandran is life member of various prestigious organizations like Indian Association of Dermatologists, Venerologists and Leprologists, as well as Association of Cutaneous Surgeon of India, Indian Medical Association, the Hair Research Society of India, and also World Vitiligo Research Foundation, New York, USA. Dr. Ravi Chandran has also conducted many clinical trials with Apollo Spectra. Before I hand over this session, I would like to tell that if you have any questions during or after the session, you can type below the video in the box given below the video, and we shall try to accommodate as many questions as we can. But if any questions remain unattended, you can contact Dr. Ravichandran sir on his email ID, which is simple, that is Ravi RAVISKINDOC, that is raviskindoc@gmail.com. RAVISKINDOC@gmail.com. And I will now hand over the session to Dr. Ravichandran sir. Over to you, sir.
Yeah. A very good evening to one and all, and thank you, Dr. Rohan, for your kind words of introduction. And thank you, the Brinton Pharmaceuticals, for arranging this program on master classes on vitiligo, where we are doing a second program today on the vitiligo surgical management. So I'm very eager to deliver my experience all these years where I have done procedures on these patients with vitiligo. Is it in full screen mode, Roman? No.
Yes, sir.
Okay. Thank you. And today's topic will be on punch skin grafts. So this is a very interesting, easy and simple method. We all as postgraduates, we started doing this. I started doing this way back some 20 years ago. Learned these techniques from our professors and literature, and then started venturing on this new procedure. Those days, vitiligo surgery was not much taught in the colleges, schools, and other things. And of course, this is definitely an interest was given to me by my professor, Professor P.N. Bail from New Delhi Institute and School of Dermatology. And of course, able support from my professor, Dr. Patrick Asdian, and my colleagues and patients here. So I'll be taking you to a series of slides and how this can unfold. And then maybe postgraduates, young dermatologists can definitely try their hands on this procedure, simple, easy procedure. And whatever experience I have this in this topic, I will try to proceed well. These are the topics which we going to do. We did one on non-cultured melanocyte epidermal cell suspension. Today is this topic on that. The third and the fourth, I'll be combining ultra-thin epidermal skin grafts, blister grafts, and hair follicle melanocyte, trying to include cultured melanocytes. That will be the recent advances at a later date. Okay, bringing the color back. So this is the melanocyte. We all know that it's the cell which is derived from the neuroectoderm, which travels down from the neuroectoderm to host itself in the layers of the epidermis, basal layer, and also in the hair roots called hair follicles. So they home there and start producing its pigmentation called melanin, which gives you the color of the, depending upon the Fitzpatrick classification, we have the 6 types there. So the color is brought back by these melanocytes, which synthesizes melanin and dispersed to the adjoining neighboring keratinocytes called, we always Fitzpatrick's classification. Those days we used to read that epidermal melanin unit. So to give a small introduction about this for the newer visitors today, new delegates today, we define vitiligo as the most common disfiguring dyspigmentation of the skin characterized by acquired white patches with an unpredictable course. We have quite a number of years, we have seen that the vitiligo becomes a little unstable and we cannot even predict the course. Even after treatment, it can relapse. So that shows that this young boy has got a nice segmental vitiligo. Probably with treatment, he is able to get some small islands of pigmentation, probably from the peripheries or with medical therapy. So this is how I will tell you that how this vitiligo is seen as a depigmented patches of unpredictable course. It has got a very big, very many clinical spectrum of vitiligo. Newer types are also emerging. As you can see on the left side photograph, it's got a segmental vitiligo with losing its pigmentation in the hairs. And this gentleman is started with acrofacial vitiligo called lip tip vitiligo, but now he's developed little patches here and there, particularly extensive lesions here. It's almost like milk white patches with a little very difficult condition to treat, but we can definitely arrange how to proceed with this in this last few more classes of master classes. I will tell you how to continue to this treatment and try to help these affected individuals with the depigmentation disorder. Vitiligo also due to this kind of a hair color. No, there's a lot of secondary leukoderma, as we can always call this contact depigmentation. So that is also there in this lady. Sometimes patients do have extensive vitiligo, generalized one, but some retention of pigmentation is unsightly. So people want this to go, and then so can you remove this pigmentation on the patch here on the face. So we can also methods to remove this pigmentation. This is of course biballism, as you all know. There are a lot of many conditions which are characterized by this depigmentation in these areas of vitiligo. So this is called the typical depigmented patches in fibrosum. These are all spectrums, so that we do see different types of vitiligo condition occurring in different age groups and affects these individuals in there are some people who are not very concerned about it. Some are very much like this young girl is concerned about this repigmentation. So we tried, I actually removed this pigmentation by means of a method of, she's become like an albino. She's very comfortable. Okay, just to introduce this topic of surgery. So medical treatments are ineffective in many patients, and surgical methods have therefore been developed. Time memorial that early days, and our professors and elders and Dr. Gauthier, Dr. P.N. Bell, Dr. Falabella, so many of the senior consultants have given a way to how to proceed and then start repopulating the depigmented areas of the skin with the autologous melanocyte transplantation. We should understand the basic pathology of vitiligo because it involves chronic loss of melanocytes in the areas of depigmentation, as you all know that. Vitiligo macules could pass through two stages. The first stage is the reversible with partial melanocyte loss. As you see, the lot of skin containing many number of melanocytes, which produces melanin. And then in some areas, it is reversible partial melanocyte loss. So this is called the partial melanocyte loss. And the second stage is irreversible with total melanocytes loss, wherein we try and do some surgical methods and try to repopulate the depigmented patches with the own melanocytes so that we are able to get the pigmentation back there. What are the current surgical modalities? All of you, the postgraduate, are very familiar with this classification, which has been formulated from our Association of Cutaneous Surgeons of India, where we classify this topic into tissue grafts and the cellular grafts. Tissue grafts include thin and ultra thin split thickness graft, STSG, suction blister epidermal grafts, mini punch grafts, which I am going to talk to you today, and the hair follicle grafts, which are also very interesting and very useful in certain areas. And then when you talk about hair follicle graft, we are also able to do this hair follicle melanocyte cell suspension and then culture of the stem cells of the hair follicles. Going into the cellular grafts, what are the types of cellular grafts, which are all very familiar across India? That non-cellular NCES, called non-cultured epidermal cell suspension. The second one is cultured pure melanocytes and the cultured epidermal grafts. Autologous non-cultured extracted outer hair root sheath cell suspension. This is also very similar to your NCES. This is a very easy technique. So it all involves by the method by which we isolate the melanocytes which are there in the basal epidermal layer as well as in the hair follicle basal layer, so that we suspend them and then try to arrange it to be given to the donor areas. This is a very simple classification. I think before I proceed with that, I thought I will give you a small classification. The classification is an orderly way of thinking so that we will be able to take up the project in a correct way. I did this topic of a very easy and easiest method. Now it needs some training. So talked about last time that on cellular grafts, where in the melanocyte keratinocyte cell suspension technique. Just to show you what are the simple equipments you require, a small tray you require surgical. The most important thing is this culture media. We have the trypsin 0.25% EDTA and trypsin inhibitor and Dolby Course modified Eagles medium. These are the prime ingredients or materials we require to start producing the melanocyte transfer technique. So veniapeptidase and forceps, all these things are available in any of the laboratories or in the operation theater. So very simple technique, small bit of skin and isolate it and then put it in 0.25% trypsin and incubate it in the incubator of 38 degrees, and then after 30 minutes to 90 minutes, we start taking it and then try to separate the cells. And then you can take it in a 1 ml syringe so that this is a pure suspension of a melanocyte keratinocyte, and do a dermabrasion either by using a micromotor diamond burst or a hand dermabrader, or you can also do it with a carbon dioxide laser resurfacing. You can also do a cryoblister later. Maybe you can inject into that. When I talk about blister grafts, I'll tell you. This is how it is spread onto this dermabrated patches, and the transparent collagen sheet is placed on top of that, and the dressing is performed After 7 to 10 days, you can remove the dressing and the follicular repigmentation as well as diffuse nice brown good pigmentation occurs following the transfer of the autologous melanocyte cell suspension. This is just to show you how effective this young boy who had a vitiligo from the age of 5 and he came to me when he was 15 years old. You can see the white hairs called the leukotrichia hair. So this is an ideal patient for a melanocyte cell suspension technique. This is after 3 months after the results. You can also see some of these hair follicles called retrograde pigmentation do occur, and the hair follicles can become a little more darker in shade. And of course, we do see small islands of the periphery called the halo, which can easily be tackled at a later date. So this gives you excellent results with good textural quality, color matching, and then easy technique, and the patients will be very happy. This is the absolute indication for NCES in these patients with the segmental vitiligo. Any part of the body can be done. The best response to NCES is segmental vitiligo. Even however, if it is large patch, we can definitely do it. Okay, before going into choosing these patients for vitiligo, we have to plan our procedure in such a way that several points have to be considered and also discussed with the patients, as well as particularly young boys and girls. The parents have to be briefed because they have a lot of anxiety, and then the questions have to be addressed well. The patient should be clearly explained about the nature of the procedure, expected outcome, and the possible side effects. The choice of the surgical intervention should be individualized as the type of the vitiligo. I was just telling you segmental vitiligo, lip acral vitiligo, focal vitiligo, like this. And the stabilities also can easily be assessed. Nowadays, we talk about stability, lesional as well as generalized stability. Lesional stability can be seen by getting a repigmentation of the follicles there in the center or the edges. Sometimes there shouldn't be any Kubner phenomenon. And if you want to do a small test, which I'm going to tell you how to assess stability by doing a small skin grafting, the sites involved like lips, fingertips, face, any segmental or any generalized lesions can be taken up for procedure. The localization of lesions also adds up to the results, and the cost effectiveness of the procedure depends upon the type of procedure which we are going to choose, is the tissue graft or a cellular grafts. Okay, coming to the main topic of today's interest is miniature punch skin grafting. Miniature punch skin grafting, also known as mini grafting, is the simplest and easiest and the best method and least expensive of all the grafting procedures in the vitiligo. I learned this technique way back many years ago, and also as when I was an assistant professor, I gave this topic for one of the MD postgraduate as a dissertation. So we tried and then observed. Unless and until we try it on our patients and see their effect, results, probably then we will believe in ourselves and the patients, the response to the treatment. So we choose this topic as postgraduates, young postgraduates. It's in a medical college scenario. Please start doing this tomorrow, so that you will be happy to. Then you can develop it in other subsequent techniques to master the art of vitiligo surgery. The procedure involves the transfer of a circular pieces of punches of skin tissue from the donor area into the small shaped pits that are made onto the recipient sites of the vitiligo patches. The donor area can be taken from the right gluteal or lateral aspect of thigh or inner aspect of arms, or from the retroauricular. Particularly, I was addressing even the last time that donor area selection is very important, because punch skin grafting can scar the donor area if you're going to do a lot of punches, which I will show you when you move through my slides. So try to limit the unsightly donor area scarring. That is why methods like which I'll be talking to you about, micro punches. So this is also very interesting event. That means mini grafting and then the micro grafting. Micro grafting also results in a scarless area from the donor area. Always take the donor area which is occluded and not seen outside, particularly in girls. The size of these punches can range from 1 millimeter to 2 millimeter, and they were all taught in the same way like initially, and they were spaced 5 to 10 millimeter apart the recipient side. So we have a small understanding that if you're going to use a 2 millimeter, maybe you can place another punch at the another 2 millimeter gap between the two punches. So that also gives you good perigraft migration of pigmentation. So sometime you can also do, probably if the disease is stable and repigmentation, you can also space it little apart, so that the uniform pigmentation can be achieved spontaneously or with a kind of a phototherapy. Punch grafting is a safe and simple and widely used technique in vitiligo. And inclusion criteria is very important, that proper choosing the patient is gives you the excellent results. Patient with segmental vitiligo under medical treatment can be taken. The age is between 18 to 60 years. Patient is willing and able to give written consent, which is stable for 12 months without any systemic therapy, or 6 months with topical therapy also can be taken. As I told you, absence of new lesions, an enlargement of existing lesions like the kubernetes, all these things. Vitiligo lesions on the extremities and trunk larger than 5 into 5 centimeter. Any site is taken for any procedure, particularly for tissue grafts and cellular grafts. And if there are a lot of patches are there on the body and other places, it's better to take the patches to begin with on this exposed site, which is cosmetically disturbing to the patients. We do exclusion criteria, look for any kind of a keloids or hypertrophic scar, whether any kind of phototherapy allergy or anesthesia allergy. Cytokine sensitivity have to be performed. We are going to infiltrate anesthesia. We are going to do patients who are pregnant or breastfeeding, patient not competent to understand, because this is going to take time. It is not that one day we start doing, tomorrow you get the pigments back. So it might take 3 to 6 months to get the uniform spread of the pigmentation aided by medical and phototherapy treatment. Patients with the active halo nevi are to be discouraged in doing this because they can get a kubernetisation. To the instrument. So these were all taught long ago, that we have these punches, no? The orange-rich punches was the one which I bought long back. I'll show you. These are all called disposable punches of different shapes and sizes are available, 0.1, 2 millimeter, 1.5, 3, 4 millimeter. And we have the typical punch holding forceps and micro scissors called the mini scissors are available, S-shaped curved scissors called the iris scissors. And we have small, even lots of instruments are very useful, but minimal damage to the tissue is the principle. When you take out the crush injury should be avoided. The quick transfer of the grafts to the donor area gives you excellent improvement, because to avoid secondary bacterial infection. There are lots of disposable. Of course, this is a method by which we can autoclave it. So we can even sterilize it with a sterilizing method called ETO, and can be reused many number of times, because holding it a little handy, because with this technique you can harvest more than 500 grafts. So this is useful for patients who require large number of punch grafts to be taken with a metal unit, which can be reused and autoclaved till the burr gets blunt. This is the one which I bought long ago. This is from Robbins Instruments company called Chatham, New Jersey. These are all called HT punches, but you see the nice grip there, so they can easily grip all these punches and drill it onto the donor area, and then a very easy method. Still available. If anyone wants to get the finest instruments, please go on to the Robbins Instruments, Chatham, New Jersey. So you can order diamond burrs, hand engines, micromotors, punches, hair transplantation kit. Everything is available there. You can always import it, and because they last long. This, remember, I got it, when I got it in 20 years ago. Still I'm using it. So that shows that proper maintenance of the instruments is mandatory, that you take extra pain and care, so that we need to have a trained staff for all these procedures. I was just telling you that all of us must try to get this dental micromotor called the Marathon or whatever it is. It is called the hand engine from Robbins. And we have a straight hand piece called NSK with a small burrs and a foot switch. All this can be easily, the RPM can be adjusted. Of course, I would just attach a small diamond burr, but you can always attach 0.8 millimeter. If you have seen a hair transplantation surgeon working on these methods, they always have these punches, which is called 0.8 millimeter, so that we can, instead of scalp hairs, we can always take it from the donor area like gluteal or thighs, maybe very fast. Actually, you can do around 100 punches in hardly 5 to 10 minutes. So that shows very easy method of harvesting 0.8 millimeter punches, so that when you transfer that, the scarring is minimal. Both donor as well as the uniform pigmentation is excellent when you do it's very small one, so one has to be very careful. You need to wear a lens loop and identify and have a team of work, sit there and then try to spread these punches, because 100 to 500 punches, many you have to separate it properly and drill it. Donor area is to be placed properly. So this involves a kind of an experienced technique, very easy technique. The procedure involves the preparation of the donor and recipient sites by cleanly shaving the hairs and then painting with an antiseptic solution. Anesthesia is given generally by local infiltration with a 2% xylocaine or 1% xylocaine with adrenaline, because donor area can bleed. You need not do with the recipient sites. With a thin long needle will be better to do intradermally. No, long needles are very useful. You can get it from the dentist. They use a long needle, and so that you get a tumescent anesthesia. It is very easy for you to get a tumescent, so that it is punching will be very easy to, the holes can be made. 1 and 1 millimeter punches are used generally. Mark punches holes to the level of the epidermis and cut the base with the size of a 11 blade or 15 blade. The tissue is taken or transferred to a sterile cups containing buffered normal saline. Simple technique, a tray can be easily set in the theater, and the trained staffs can be able to autoclave it and give it to you, so that we can start doing it. You can also do a xylocaine infiltration or a finger block or a regional block. If it's still large area, you can always take the help of an anesthetist who is there in the theater. I'm just telling you, when you give a small injection of local anesthesia, which is very painful, sometimes you can always use a topical EMLA cream if it's a small child or a pediatric age or a young girl who is scared of injections, needles. So we apply a little Prilox topical EMLA cream for 1 hour under occlusion, so that the infiltration of these areas are very easy. When you take the needle and then start withdrawing, you get a small wheels there. So that is called the typical intradermal tumescent anesthesia, so that when you start punching, it comes beautifully well, so that the holes are made perfect without any kind of a distortion, or whether we use 1 millimeter or a 2 millimeter punches. So local anesthesia forms the sheet anchor. Topical EMLA is little most difficult, but if you can use it for 2 hours under occlusion with a micro grafting with a hand engine, that will be much better. You have to have a local anesthesia for a punch grafting. And of course, these are all disposable punches. You can always take with a small area, it bleeds, and then as and when you can make 100 punches and then maybe harbor 1 or maybe assistants can pull out the punches driven here. As you can see here, the donor area is taken on the lateral aspect of the thigh, or the gluteal thigh aspect, outer upper quadrant of the gluteal muscle area. And you see the, probably it must be more than 2 millimeter, maybe 3 millimeter. So we have taken around say 20-25 punches here. We take the jeweler's forceps and then trim it, and you see a 15 blade and then cut it away the base. And this is how generally it is done. You see all the punches which are floating on the pits are removed by the use of a 15 blade with the jeweler's forceps, and it is taken out in such a way. And you can do this donor area with a bactigrass or a sofratulin dressing and glasses and the tight bandage with a, so that doesn't bleed, and you have to remove this thing after 10 days. So this is a very important, easy method of donor area harvesting. And after taking out these, try to take a buffered normal saline in a sterile container, so that all the punches are floated here. Sometimes what happens, you can go a little deeper to the dermis. So if you don't want to do that, you can take each one and then with a small mini syringe, mini micro scissors, you can always trim the base layer, what we used to do it for a hair transplantation. Sometimes you have pad of fat layer there below the thing. So this is how this is transferred to the dish containing buffered normal saline, and is ready for donor area implantation. A very easy method of just showing you a small video clip of where it is quickly done. Sometimes you wanted to do around 1000 grafts or 500, it hand becomes a little more painful. So this is an easy method. So, but best procedure for this punch skin grafting involves the areola and the nipple. As I was just doing it halfway through, took a picture just to show you the understand. It's a little tough skin, thick skin, but still you can make it. All this, it also looks like Montgomery's tubercle, so that once repigmentation occurs, you get a nice cells covering up, because ultra thin graft melanocyte cell suspension may not work here. So this is a very simple, easy technique. Actually, this patient is got a segmental vitiligo. We tried this long years. I think my postgraduate did this when we gave the dissertation. As you can see, a segmental refractory case. You see a nice placement of the punches there, which is around maybe 2 mm. Now you can see the after 1 month, you can see the perigraft migration. The central pigmentation is a little darker to begin with and diffuses on to this area. Even small islands like as in the periphery, we already transferred few punches. So this is usually takes 3 to 6 months to color match. It can be a little more darker depending upon the size, patient skin color, texture. So this is followed up with the top phototherapy in the form of a topical and oral therapy can be. Exam lasers also can be targeted phototherapy. Exam lasers also can be done. Nowadays, things are very useful so that we can get the pigmentation in the faster way. I was just telling you about this role of stability. So how do you assess stability? By doing a surgical intervention. So that if you want to do a large case, either for a procedure of an NCES or an epidermal graft or for the punch grafting, just do a small test punches called test mini grafting. We take around half a dozen punches and then put it on the patch, which is maybe like a small focal vitiligo, and wait for a month or so. The pigmentation starts building up and then perigraft migration, and the whole patch can become covered, and wait for whether there's any further destruction of the melanocytes by autoimmune process. Then if it is not there, you can always go ahead and proceed with the other areas where at one session, maybe as I told you, any vitiligo procedures might need more than one session. So I identify the exact size and the patch the patient wants. Doctor, please try to help these patches, which is the first one. So please acknowledge them so that we will be able to. But we have to assess clearly whether the patch is the patient telling is stable or not. For that, this test mini grafting called Palabellas mini grafting technique is popular. I have already done so many patients. Of course, now clinical parameters are very clear that this is a very interesting tool. Of course, after doing any punch grafting, so we do expect some punch complications of any procedure. What are the common complications we face? We see the cobblestone appearance. If you are not able to identify exactly the size of the donor graft as well as the recipient site holes, then it may prop up and then it heals. And then once it heals, it is very difficult condition. It forms small papules, and it's hard to remove it and doesn't even flatten, and it's very difficult. I have done even excision of these punches, hundreds of them, and try to do some other procedure. So cobblestone appearance can be easily be avoided. If you want to do 100 grafts, take 1 or 2 donor and recipients, see whether the 1.5 millimeter snugly fits, or choose a 1 millimeter punch for the donor and transfer 1.5 millimeter. They all can be tested on the table. Polka dot appearance, if you don't space it properly, the perigraft doesn't go well and you have islands of pigmentation. Depigmentation of the grafts can happen. Perigraft halo can happen. Graft rejections can happen. It can be due to surgical techniques or dressing techniques. Dressing has to be adhered dressing for a period of at least 10 days. Keloids and hypertrophic scarring do occur. The variegated appearance depends upon the color mismatch of the recipient sites. I told you, we use it, space it, and clearly on the donor area and the recipient sites, we avoid all these complications. Kubner phenomenon, depigmentation at the both donor and recipient sites. That is why you do a test patch to prevent the Kubnerization. This is because you have chosen an unstable vitiligo. Trying to do all the patients, both the donor area and the recipient area, can result in failure. Again, it's one of my patients who actually came to me for what can be done for this. This is technique which is done by maybe a 3 millimeter punches or 2, resulting in a lot of cobblestone formation. This is the most difficult condition to treat, cobblestoning. I try to do a dermabrasion, surgical dermabrasion. It doesn't generally go well. Similar punch out, we punch out all these lesions, make the punch holes heal well with little scarring, then you can go for either an ultra thin or a melanocyte cell suspension technique. So try to avoid complications by choosing the proper method and the proper technique. Take guidance from your elders and seniors who got experience. And in India, we know that we have got huge number of seniors who have done excellent job in research as well as in our new venture on vitiligo surgery. Reverse Kubner phenomenon, probably a good job has been done, but you can see the small depigmentation of the punches, which is probably, and though the hairs are darker in shade, but the patches are not active stable. So that is why the unstable patches, when you transfer a pigmented punch, it all get depigmented. It's called reverse Kubner. Maybe if the patient also must be screened for the donor area, harvesting area, even that would have developed a small depigmented complications. So punch grafting can result in complications. Lip vitiligo, of course, my one or two colleagues in India is very famous for doing vitiligo procedures on lip. Anyway, I feel little uncomfortable in doing lip graft, so I am little comfortable with an ultra thin graft. From the next program, I will show you. Become easier and simple. This takes a lot of time, and of course, you got to do a mini graft, as I told you. Probably it takes a lot of time. It can leave a scar, and variegated pigmentation is very common. When we are going to get a uniform, of course, people, our experienced colleagues are able to achieve very good results. But anyway, I'm not very comfortable with this. Anyway, I did try to do that, but this is how the results came. So it all depends upon how you are going to choose your topic and then your patches to proceed. Just going into the review of literature, please go through this Fallible as my favorite. I always used to wonder how this gentleman has come out with the good answers, like Fallible and Dr. P.N. Bell were counterpart. They are very thick friends. Surgical treatment of vitiligo, why, when, and how it's done there in the 2003 article. Please go through that. You will be knowing how things have started from early days. So it has taken a journey of always Dr. Devendra Prasad says that journey of vitiligo surgery started way back, and now how we are almost doing a melanocyte cell line culture. So that's how it has happened. And Minigraph testing for vitiligo, I was just telling you, this is a nice paper, reduction of stable lesions of melanocyte, which I told you. This is again from Fallible. So please follow this kind of a literature review before you study well. Learn the art from elders and experienced people, and then have a nice review of literature so that you master the subject and trying to venture out in this topic of vitiligo surgery, whatever tissue grafts or cellular graft. This will give you good confidence to give an excellent results to the patient. And by doing repeated procedures, you will be able to master this art of vitiligo surgery. Vitiligo surgery is an art. For that, one has to have a commitment. One should have an interest. So I will be happy to teach you, and then hope this program is going very, very well, because you know that vitiligo patients are just differently colored. Let us add color to their life. This is a very important statement. I think all of us dermatologists or patients care for their vitiligo patients. And I think it's a long drawn disease, but definitely we will be able to help them both emotionally and disease wise. We will be able to achieve very good results at the end of the day. So thank you so much for patient listening, and thank you one and all for giving me an opportunity to present this topic of olden yesteryears, but still it is practiced in most of the medical colleges. Young postgraduates are very fond of this technique before they venture into newer advanced treatment. Thank you so much. Thank you very much.
Yes, sir. Yes, sir. Thank you very much, sir. That was quite enlightening session. So before we end up the session, we have some questions coming up. Okay, sir, can we stop the screen sharing? Yeah.
Yes, sir. Thank you.
Yeah, sir. So great, sir. We have quite a couple of questions from Dr. S.K. Punshi, sir, from Amravati. And he wants to know whether are there any rejections of punch skin grafts, and if yes, what could be the percentage of this rejection?
Rejections are, as I told you, surgical dressing techniques. Suppose if you are using a large sized one, mismatch of the punch donor and recipient. When you remove the dressing, it can just fall and go away. So that is one area. Rejection occurs not at the graft level. Graft level is a traumatic, more of a procedure wise. Whereas repigment, as I told you, if rejection also can be assessed by depigmentation of the transferred punches. It's called the reverse Kubner. So generally, if you are able to plan it well, space the punches clearly, and the number you calculate it, and then do it, I think very nicely. But always what I store mechanical failure can do happen when you remove the third day. The patients can remove the dressing or it can slide off. So always I keep a little bit of punches, which is extra punches in a buffered normal saline in the refrigerator, so that after 48 hours, when you remove the dressing or anything, you can always transfer it to avoid failure. It's a failure of graft holding on to the punched area. Of course, autoimmune disease phenomenon can happen. It can also restrict, but it is more of absorbed by depigmentation rather than any kind of event.
Yeah. Okay. There is second question from him. Vitiligo patch, he says, may have multiple colors in few of the cases. So does it hamper in the punch skin grafting, or any comment
Yes,
on
a
this?
very good question. Always we call this, sometimes we take up patients who have got a trichrome vitiligo. With medical therapy, one can have a trichrome vitiligo, but some areas are still depigmented. You can attempt, but generally the patients are very comfortable because they want the depigmentation to be dissolved.
Okay.
They don't mind giving an hyperpigmentation or multiple color shades. So hyperpigmentation and can happen after any other technique. That is why the newer methods like NCES has avoided all this color mismatch and the hyperpigmentation and the textural quality. All can be resolved by the newer technique of NCES cell suspension method.
Great, sir. Another question, that's penile vitiligo or maybe condom leukoderma. Does it have any indication of punch skin grafts?
For a glance, it's very difficult to do it because the most painful condition to do. We always learn this technique from our urology colleagues, but they also tend to give it's very difficult, thick, hard skin to do punch out. I generally don't do punch grafts on the glans penis, but we prefer an ultra thin graft. Very easy, but placing the ultra thin is the most difficult. But nowadays we have good dressing techniques, and we can I always use a transparent collagen even for dermabrasion followed by an ultra thin. Of course, cellular suspension also can be done on the glans penis and vulvar skin. So many times, actually, I demonstrated this long back in our Vitiligo conference in Bangalore, that it was one of the most sought after program on that day. Thank you.
Okay. Question from Dr. Gaurav. He wants to know this: is there any difference between size of the donor site and recipient size punch?
Yes, this definitely happened. This is the reason that one can have a sunken pits or a cobblestone formation. To avoid that, as I told you, if you're going to take a 1.5 millimeter donor and recipient, take that 1.5 millimeter donor skin and try to put it into the punches of the recipient side, same size. If this is going to be little smaller or larger, choose the other agent. So you can go for 1.1 millimeter or 2 millimeter, depending unit. That's why as always here, trial and error. Take one or two, try it out on the donor area if you're going to do more than 100 to 200 punches to avoid these complications.
Okay. And sir, there is a last question from Dr. Punshi sir, that is tofacitinib, which is a Janus kinase inhibitor, is it helpful in this treatment of vitiligo?
Anyway, I will be talking to you about the recent advances in the medical management, the role of JAK inhibitors later.
Correct.
But I have not started on post-procedure so far in my patients because it's a new molecule. It is still not come to India. It has not been approved yet. It's the phase 3 trial is there, ruxolitinib. I think we need to wait and watch. If it's a localized area, I do not know whether it may be very useful for spreading vitiligo where it is early stages, but it may not be very useful in the case where there's a complete total loss of melanocytes.
Great, sir. Great. Okay, sir. With this note, we are truly actually delighted, sir, after listening and watching you explaining this whole procedure and making this procedure even simpler, so that it will imbibe more confidence in the young budding dermatologists, and they would definitely try to implement this technique in their career ahead. And we are sure doctors attending today's session would love to attend the remaining master classes, which would be happening in upcoming months. I have mentioned these topics in the screen. I hope all are able to see it. The ultra thin epidermal skin grafts, then followed by blister grafts and hair follicle melanocyte grafts, cell grafts, medical therapy, and recent advances in vitiligo. These are the upcoming topics which we will be having in this masterclass series. And I have mentioned the mail ID of sir, that is raviskindoc@gmail.com. If you want to connect with him for any guidance, that is the email ID. You can note down. And till then, I take your leave and wish you all a great health and success ahead. And thank you, Dr. Ravichandran sir, for his time and invaluable insights on the subject. And we will meet again in the next master class. Thank you.
Thank you, Dr. Rohan. Just before concluding, one question from my side always happen.
Yeah.
Treating a palmar vitiligo and the vitiligo over the soles is the most difficult condition to treat. Best response will be for a mini grafting. So palms and vitiligo on the palmar side. This topic will be very interesting, but only thing we need to give a finger block or a wrist block to proceed with the mini micrografting techniques for the vitiligo involving the palms and soles, because many people are concerned particularly on the palmar vitiligo. Though we are able to cover the areas of the dorsal aspect of the fingers, but palmar vitiligo, one of the best response is mini punch grafting under wrist block and with the mini micrografting. So this will be a good take-home message, and this is absolute indication for palmar vitiligo. Thank you, Dr. Rohan, for your kind coordinating this whole program. Hope our viewers benefited from today's lecture.
Our pleasure, sir. Our pleasure. Thank you. Thank you.
Good night to everyone.
Good night. Good night.